Hi, we're here with Dr. Donald Kotler, Chief of Gastroenterology at St. Luke's Roosevelt Hospital and a Professor of Medicine at Columbia University. And we're going to talk a little bit today about Abacavir and cardiovascular disease risk. There's some data being presented here today from the SMART study, and I'm wondering if you could tell us a little about what you know about the data that's going to be presented and what it might mean.
Okay, but first a little bit of background.
Yeah.
One of the interesting parts of science is that if you ask a good question, you get a good answer. Mm-hmm. But it's not always the answer that you thought. Mm-hmm. To start, before the SMART study, last year the big news was a DAD study. Mm-hmm. And it was a study that was designed to look for toxicities of antivirals. Mm-hmm. And in the analysis that was presented last year, or at CROI, the investigators were looking to document nucleoside-associated cardiovascular risk with the strong assumption that it would be related to stavudine and zidovudine. Instead, they found no increased risk of stavudine and zidovudine, but they found a very significant increased risk with Abacavir. And they showed also some increase in risk with Videx, DDI. Totally out of the blue, totally unexpected. The investigators tried as hard as they could to find their mistake, but could not. Well, this year they decided to look at another database. These are not controlled trials, but rather retrospective analyses of ongoing cohort studies, which is not necessarily the best way to look, but in case of the DAD study, it was 33,000 people, which meant it was a very powerful look.
Right.
In any case, the investigators decided to look at another cohort, which is the SMART cohort. You all may remember the SMART cohort as another example of science gone well and investigators being wrong. The SMART study was one in which the assumption was that continuing on medication was bad for your heart. Starting and stopping medication would be better for your heart because less toxicity from the medications, and the answer was the opposite of what they were looking. In any case, the SMART study has fewer patients, but still several thousand, 5,000 or 6,000 patients, and the investigators tried to reproduce the data that would suggest that the ongoing use of Abacavir somehow is related to cardiovascular disease, and in fact they did find that was the case. Still cannot explain it. It doesn't seem to be related to cholesterol or lipids in general. It may well be a different mechanism, one that we hadn't anticipated, but that's not so surprising for Abacavir. After all, the hypersensitivity reaction is really limited to Abacavir. It's not like a nevirapine rash. It's something really different that in fact is immunologically restricted, something that would only occur in people of a certain genetic makeup. Well, maybe the myocardial disease is the same. That's related to a specific kind of immune reaction or inflammatory reaction. Perhaps it occurs in the heart and it is related just to nucleoside toxicity. Perhaps it's related to something that's going on in the vessels that is causing some inflammation in the vessels that will make it for coagulation to occur and the vessels to clot off. I should say that GlaxoSmithKline looked over their database of 54 different studies, and again, several thousand people, and was unable to reproduce that data. You might be concerned because GlaxoSmithKline kind of has a bias. You know, they have a dog in that race.
Right.
It's their drug. But it may be that both groups are right. It appears that in the SMART study or in the DAD study, the higher your underlying cardiovascular risk, the more the Abacavir may be causing harm. And in fact, the underlying cardiovascular risk in the GlaxoSmithKline group studies was actually kind of low. Somebody with really bad cardiovascular risk probably wouldn't be included in the study.
Right.
So, and the group with in the GlaxoSmithKline trials were actually quite a bit younger than the average age of the people in the DAD trial. I'm not sure about SMART. So it may be that they're both right. The answer is still not in. What it means for practice is uncertain. Certainly many clinicians would think if there's a really high cardiovascular risk underlying, that maybe Abacavir is not such a good idea. Although I would think that the Abacavir effect would still be much less than cigarette smoking, and we as clinicians had better get on the stick to try to get our patients to quit smoking, exercise more, etc. But I suspect that over the next year or two, there's going to be a lot more study of Abacavir, including hypothesis testing, not just hypothesis generation, to try to figure out if there is a real risk, how is it happening, how might we be able to predict it. I mean, one of the triumphs of this form of science was the fact that the hypersensitivity reaction, the Abacavir hypersensitivity reaction, was something that scared many clinicians away from using it, and the risk of hypersensitivity reactions has almost disappeared since the HLA-B5701 testing. I pray that something similar will happen with Abacavir. I hope we don't lose that drug.
Right.
I just hope we find out what's really going on.
Great, thank you.